to introduce himself.
Hi, everybody. I'm Jonathan Church. I'm a business analyst here with Qualidigm, and you'll probably be hearing a lot from me throughout the program. I'm excited to work with all of you.
And we also have with us, I don't think you can see her on camera, but Annie Fox.
Hi, everyone. I am also a business analyst with Qualidigm and looking forward to this program. And any questions you have, feel free to reach out to me. I'm at Qualidigm Tech.
Great. Thanks, Annie. So once again, I'm going to turn this over to Jess, where we would love to have the faculty introduce themselves. Jess, you want to lead that introduction?
Sure. So we're really hoping, because this will be the team, that we'll have you all meet each other this morning. And in order to be able to make sure we keep things rolling and going smoothly, we're going to ask you to just give us your name, your title, where you work, and a brief history of your work in relation to caring for, supporting folks with dementia in the community. And we're going to limit that to a minute. So I'm going to set a timer. And if you hear it go off, that's your cue that you've reached your minute, and we'll move to the next person. So why don't we go ahead and start with Cinda. And you're muted still.
So this is
Okay.
Okay, there we go.
How is
Perfect.
Okay.
we got this? I'm on phone and laptop everywhere here. So hi, everybody. I'm Susan Ankoviak. I'm the Vice President of Programs and Services at the Massachusetts, New Hampshire chapter of the Alzheimer's Association. I won't need a minute, but just to share that we have a couple of our staff from the association who will be participating actually as faculty. I'm here today just having had the pleasure of talking mostly with Jeff about this opportunity and just wanted to be familiar with the program and support our staff who will be faculty. Briefly, the Alzheimer's Association provides programs and services to families in the community, including a 24-hour helpline, education programs, support group, and social engagement opportunities for people recently diagnosed and their families. There's a great deal to us, but that is sort of a quick synopsis of our programs and services. But thank you. We're delighted actually to be a part of this.
Terrific. And how about Cinda Daunton?
I'm the elder care clinician for a county mental health organization, Rutland Mental Health in Vermont. And I provide direct care to folks with dementia by counseling them in their homes. And I also have been providing support to caregivers of people who have dementia directly for several years.
Wow, you guys are great. How about Mary Val Palumbo?
Okay, I'm unmuted. Hi, I'm Mary Val Palumbo. I am a geriatric nurse practitioner. I work at the University of Vermont memory program where I see patients and families who have been diagnosed with dementia. I also teach at the University of Vermont caring for the older adults.
Excellent. And how about Anne-Marie Olson-Hayward?
So, hi, I'm Anne-Marie Olson-Hayward. My current position is the Director of REAP Services here in New Hampshire, where we put counselors into caregivers and patients' homes for up to 5 free visits. Prior to that, I worked as a geriatric therapist at a geropsych facility, working with caregivers and patients with dementia across the whole disease spectrum. And then I have 15 years of inpatient hospital experience working in crisis situations with patients and caregivers. So I'm really excited for this.
Excellent, thank you. How about Allegra Miller?
Hi, sorry you can't see me, we'll figure that out. I live in Burlington, Vermont. I am a caregiver for my husband, who 13 years ago was diagnosed with Parkinson's disease and Lewy bodies dementia. Before that, before becoming a full-time caregiver, I was a full-time educator, ending my career as a principal. So this outreach is really exciting for me, and I'm really anticipating some great things coming from it. So thank you for including me.
Excellent. Peter Baker. Oh, you're muted.
There we go. Hi, this is Peter Baker. I'm the program director for the Alzheimer's Association Maine chapter. I've been here for a little over 5 years, and prior to that, worked in long-term care, assisting caregivers and people living with dementia. As Susan mentioned, we offer a lot of different resources for all sorts of audiences that are navigating the disease, be it first responders, be it primary care physicians, healthcare specialists, direct care workers, and caregivers and people living with dementia themselves. So really excited to be here and be part of this group.
Excellent. And Ellen Thompson.
Hi, I'm Ellen Thompson. I am a retired community case manager and parish nurse in the Upper Valley of New Hampshire and Vermont. And I've enjoyed this work for a long time and ran a Alzheimer's dementia support group for a number of years while I was working at Dartmouth Hitchcock. I'm really excited to be joining this group, a little intimidated by all of your experience. Thank you for having me.
Excellent. And Tom User.
All right. Happy to be here. I'm Tom Muser. I direct the Center for Excellence in Aging and Health at UNE. We're 1 year old, or just about. Prior to that, I directed the Master of Science in Gerontology program at the University of Missouri. And prior to that, I was one of the co-investigators for the NIA-funded Alzheimer's Center at Washington University. So I've been involved in Alzheimer's disease pretty much all of my 30-year career as a psychologist. In my prior job, I taught a graduate level course in gerontological assessment, particularly in-home assessment of cognitive change. So I tend to wear lots of different hats, and I bring experience from many different angles to this, but I'm very glad to be here.
Excellent, thank you. And how about Dr. Cliff Singer?
Thanks, Jess. I'm Cliff Singer. I'm a geriatric neuropsychiatrist, and I direct the older adult mental health and neuropsychiatry program at Northern Light Health in Bangor, Maine. And I'm mostly at Acadia Hospital, which is a psychiatric hospital in Bangor. Here we have the Mood and Memory Clinic and the Alzheimer's Disease Research Program. And I am the former faculty lead or medical director of a project ECHO that just ended. It was the Northern New England Older Adult Project ECHO, and so it's fun to be part of this effort. And I see some old friends and new friends. Hi, Mary Val. Mary Val and I used to work together when I was at the University of Vermont.
That's awesome.
Yeah.
How about Laura Davey?
Hi, so I am Laura Davey. I am with the University of New Hampshire, both affiliated with the Institute for Health Policy and Practice. I oversee long-term care and aging focus area for the Institute, and also am co-director of the Center on Aging and Community Living at the university, which is a partnership with between the Institute for Health Policy and Practice and the Institute on Disability. You know, personally, my grandfather had Alzheimer's disease, so I come with a lot of personal experience around that, and suffered or dealt with it for more than 15 years at the end of his life. I have an aunt who is diagnosed early onset, and my mother who has Parkinson's, and I just heard at one of our community meetings how 65% of Parkinson's individuals develop dementias and other things. So come with a personal side. Professionally, I started my career as a physical therapy assistant, and always enjoyed working a smattering of different healthcare environments, from nursing homes to home care, and experience with Alzheimer's and dementia through through that work. Now we do a lot of systems change initiatives, both with the Center on Aging and Community Living and the Institute for Health Policy and Practice. Many of that work is out in supporting community-based organizations and providers who are working with caregivers and individuals with dementia. I'm associated with the New Hampshire Alliance for Healthy Aging. We support the backbone organization for that, and also on board with the Tri-State Learning Collaborative. And
Laura, so if you're not catching the little signal,
I'm not catching that.
Yeah, you jumped in a little late in the explanation.
Like pounding me. I'm done. Bye.
I never expected Laura Davy to be the one that would.
I know.
Wow.
Whose phone is ringing? Whose phone is going on while I'm talking?
How dare they? How dare they?
Oh, boy.
Thank you, Laura.
Thank you. How about Mark Botwell? And Mark, if you're talking, you're muted. Oh, there you go.
Okay, I'm on the phone. Can you hear me now?
We can hear you.
All right, great. So Mark Boutwell, I'm the Director of Social Services at Senior Solutions, the Council on Aging in Southeastern Vermont. That means that I oversee all the case management and our helpline services. Our case managers deal largely with long-term care, choices for care clients in the communities. I've been with the agency 5 years. I also oversee the Dementia Respite Grant and the National Family Caregiver Grant programs, and provide group support services for caregivers, and also let's see, what else do I do? So I've had so I deal a lot with caregivers, and the other thing I do is options counseling, which is really meeting with families and assisting them in looking at the future and doing some planning around their needs and what options are available. And I also touch base with the elder care clinicians, the program that Cinda is part of.
Thank you so much, Mark.
You're welcome.
And how about Catlin Blackstone?
Hi, this is Catlin. Can you hear me?
We can hear you.
Oh, I'm so glad. I don't have any fancy technology here, so. Hello, my name is Catlin Blackstone, and I'm the Chief Program Officer at the Southern Maine Agency on Aging. I oversee our Family Caregiver Support Program, and I also oversee the Sam L. Cohen Center, which is our Adult Day Services Center in Biddeford. And I'm so happy to be here. Thank you.
Terrific. And how about Tamara Herrick?
Hi there.
Hello.
Hi. Hi, I'm Tamara Herrick. I am Program Manager for the Maine Health Alzheimer's Disease Partnership, which is a partnership between Maine Health, Southern Maine Agency on Aging, and Spectrum Generations, and Maine Behavioral Health Care to bring dementia-specific training and services, evidence-based services to those two areas. My background, actually I have a PhD in gerontology from UMass Boston. My dissertation was on folks who live alone with dementia and what supports they need and how they're actually accessing them. I'm really interested in pathways to care. Yeah. Am I
Terrific.
on 1 minute?
You've got 11 seconds, but you know.
All right.
All right, great. And how about Patricia, if you could introduce yourself? Oops, sorry.
Hi, my time is up. I'm Patricia O, and I provide support for Jess at the Tri-State Learning Collaborative on Aging.
Oh, you can say a little bit more than that.
And I really enjoy providing support for Jess at the Tri-State Learning Collaborative on Aging.
Patricia also works extensively with nearly 100 communities here in Maine that are doing some sort of aging in place initiatives. So she's got broad and deep experience with that. And how about Emily Vivian?
Yeah, I'm Emily Vivian. I'm the Director of Programs for the Vermont chapter of the Alzheimer's Association. And can everybody hear me okay?
Yep, we can.
Okay. Yeah, I'm the Director of Programs for the Vermont chapter of the association. And I started in my role about 4 months ago, but I have some history with adult day programming. So working with caregivers and their family members with dementia. So I'm really looking forward to being a part of this.
Terrific. And Krista, do you want to say hello too?
Hi, everyone. I'm the operations director with Jess and Patricia at the Tri-State, and I'm really excited to learn more about this program and the opportunities.
Terrific. Did I miss anyone? Hearing none, I think we're done. Thank you all. Great job.
Wonderful. Thanks, Jess, for leading that. And sorry, who did I jump on? Anyways, apologize for jumping on you, Emily. All right, we're going to launch right into our presentation, and I'm going to try and go through this next section a little quicker. Hopefully, can you see the slides? Just do a thumbs up. Okay, great. Thanks, Jess. So as mentioned, we've titled this project, Project ECHO, Enhancing the Care of Health and Health of Older Adults Living with Dementia in the Community. And we're providing care as well to caregivers. And this is our orientation for faculty. We're going to cover the following. So the learning objectives and the schedule. We'll share a little bit of what our faculty expectations are. Jonathan's going to go over some technical requirements and Zoom best practices. We'd like to have a little time to talk about some of the potential didactic topics. And then we'll go into the Project ECHO overview, best practices. We're going to look at the case template that our participants will be sharing, and then we're going to end with an actual mock, meaning we're going to go through a fake kind of case presentation, what your role as faculty is, what the role of participants are. So next slide. So the program objectives over the next course that'll take us through June 2020 will really be to increase positive health outcomes for older adults while decreasing risks that impact their quality of life, gain knowledge through the spread of best practices, will increase the capacity and confidence to support older adults with dementia and their caregivers living well, provide an understanding between the healthcare system and the community partners to help bridge those services and build a network of support that provides better coordinated care for older adults with dementia, provide knowledge on technical solutions that can help to promote safety for older adults living with dementia, and then last but not least, gain knowledge in health equity and cultural competencies and sensitivities. As the program evolves, we may even add more learning objectives as the faculty identifies the need. So our program schedule will typically going to be meeting on the fourth Thursday of every month from 11:30 to 1. Here you can see the schedule, the dates. We did move due to the holidays. November is going to be held on the 14th because of Thanksgiving is the following week, and December will be held on the 12th. So hopefully you're able to attend most of them, but we do understand life happens, you have other commitments, so we encourage you to attend as many as possible and just give us a heads up if you're not able to attend them. Schedule. You want to cover that, Jonathan?
So now is the time where we say this is your mission. If you choose to accept it, this is what we are expecting of you as a faculty member as a part of this ECHO. So we'd ask that you be able to participate in at least 7 out of 9 monthly case-based learning sessions. We understand things happen with your schedules. They're busy. You have your own day jobs. and we understand that you may not be able to get to every one of them, but try your best. And just let us know if you can't get to a session. Shoot me an email and just say I'm not able to make it next month. Really sorry. And then we'll make sure we keep you in the loop, give you all the materials. That way you can still stay kind of informed of what's going on in every session. So when possible, we ask that you attend a pre and a post huddle. So our sessions go from 11:30 to 1. We'll have everything going by usually 11, and at 11:15, if possible, we ask that you just jump on the call. This just gives us time to make sure your audio and video is working, and also just discuss anything that may come up in the session. Talk to the didactic presenter of that session, and just cover any kind of things that may come up last minute before we start. Participate in kind of a case review process for each month. This may, depending on when we get the case presentations, sometimes they're not, unfortunately, sometimes they're not like the last minute. If we can get those cases though beforehand, we send them out to you and just kind of, review the case and maybe provide any feedback. Also, if you have an article, something that you saw that would pertain to the case, you can always send it over and we share that with the cohort and the participants as well. So also be prepared to present a minimum of one didactic. Now, obviously, we do have more faculty than sessions, so not everybody will be called on, but if called on to present a didactic, which is going to usually be about 10 to 15 minutes on a dementia-related topic, and we will be talking a little bit more about those didactics in a little bit. Provide feedback in order to ensure the successful and relevant educational content is met for our participants. And then also one thing that's kind of not on here as well that we do expect as a faculty member is once we do each session, we do take a post-case kind of summarization of all the recommendations. We do send those out to our faculty and ask that you just weigh in and make any corrections, any additions that need to be done in a timely manner. Usually we give you, 3 to 5 days turnaround on those. And then we do send those case recommendations back to the presenter. So they have that to utilize for future, patients, or whether in this, may not be necessarily patient specific, but to increase the effectiveness of the delivery of care for them in their communities. And we may also be sending that out to the cohort as a whole and not just the presenter. So let's talk a little bit about Zoom. It seems like we do have some varying degrees of comfortability with Zoom. How to connect to the session. It looks like you all did awesome today. So there's a couple ways you can connect into the session. The calendar invite that we sent out, if you have Outlook, has that link. You can click on that calendar link or the Zoom link, and that will just pop up your Zoom window. That's if you're obviously on your laptop or computer. If you don't have the link, you can always go to zoom.us and then click on the join meeting button on the upper right, and then put in the meeting ID, which is provided in the emails that we send out prior to the sessions and also in that calendar invite as well. And then if you don't have access to a computer, you can always download the Zoom app on your phone, which is available for iPhone or Android. So you can go to the app market, download that, and it's pretty cool. It's just a little app on your phone. It gives you a lot of the functionality of the web-based version. You can use your camera, the phone on your camera as your camera, the camera on your phone as your camera. Yeah, I think I said that right. And but that's an awesome way to connect as well if you don't have access to a laptop or computer. So just really quickly, you're seeing this Zoom window now. Which actually you're probably not because you're seeing the slides, but when you close it out, you see your Zoom window. On the lower left, like we've been talking about, you have two icons. You have a microphone icon and a webcam icon. You left click on those icons, respectively, it'll either mute or unmute your audio, or turn off and turn on your webcam. So if you need to do something, if you need to eat something during the lunch period, that's fine. Turn off your camera by clicking that icon. And then just remember to try to turn your webcam icon back on, because we definitely want to see you. In the middle of the Zoom window there at the bottom bar, you have a little chat bubble. If you click that, it'll pop open your chat window, and then you can just utilize that to send in either links, send in recommendations, or clarifying questions if you can actually verbalize them because of something's going on. You can also chat to specific individuals, so be mindful if you do chat that above the chat box there's a little to button, and then if you click on that, you'll either say to everybody or to somebody specific. Also, just remember, if that little thing glows orange, it means there's a new chat in the little chat window. So somebody may be trying to actually get a hold of you. We may be sending you a little message. So just kind of periodically check your chat if you remember. On the lower right, you have a little button that says leave meeting. If you have to go for any reason, you can just click on that, and that'll ask you if you want to leave the meeting. And then another cool thing is on the upper right, there is an actual button. As you can see here, it'll actually say speaker view or gallery view. If you click on that, speaker view will highlight whoever's talking in a bigger box and then put everybody arranged kind of at the top in smaller boxes. If you click gallery view, that'll put everybody in kind of a Hollywood Squares view or like a Brady Bunch view. And so you can see everybody equally on your screen, which is awesome when we're all kind of talking. Makes it kind of feel like we're just all a big family and we're just all talking to each other like we were just in the room here. So a few technical requirements for Zoom, internet connection, of course, wired connection is preferred. So we have found that depending on where you are, a wireless connection can give you a little bit of instability. So you may not have a consistent audio or video connection if you're not wired. That's not always the case, but that's something you can always work with wherever you are at home or IT to kind of remedy those issues, and we can work with you as well. A microphone, a webcam, and a quiet space. So distractions, trying to limit those. So being in a quiet, safe space. And then a little thing here is if your laptop or computer isn't available, you can always use your phone, as some of you are using today, to join the session. And then some best practices, like we just said, wired internet if possible. Try to be in a nicely lit room, and remember that if you're in a room with lighting, that the lighting should be in front of your face to illuminate your face, not behind you, because that creates a shadow, and then you look like you're in the witness protection. We can't see your face, we just see the little outline. So that's the best practice. If you are, co-locating for larger groups, this isn't going to really be an issue with our faculty. This is more for the participants, where they may be a community of people joining together, and it's nice if they're all in the same room together. When you're not speaking, stay muted. This helps limit the feedback, so you're not hearing some of the noise echoing that we've heard. So just mute yourself when you want to talk. Always just unmute yourself and jump right in, and be on camera, because echo is really awesome, that it gives us all the ability to be here virtually in all parts of each of our 3 states, yet it'll make us feel like we're all together chilling in our basement like a family at Thanksgiving. And so another couple of things, if you don't have a laptop, like I said, you can always use your phone to download the Zoom app. And if not, you can always dial in from your phone or any phone to join in the session if you don't have the ability to join from a computer. And you would just dial in using the dial-in number, which we provide in the emails and the reminders, and then just put in the meeting ID. So now I'm going to turn it over to Jess, who is going to lead some discussion about our didactics for this program.
You just need to unmute, Justin.
I know. I have this weird thing when an email comes in, it hovers over top my mute button, and then every time I try to hit the mute button, it doesn't matter. Anyway, hello everybody again. So at the beginning of each of the ECHO sessions, there'll be about a 15-minute didactic, and we wanted to just get your feedback about the kinds of things that we should be presenting for our participants. And this is a little bit of a different ECHO, if anybody, and Cliff suggested he has in the past. The ECHOs have typically been used on the medical model, more in relation to diagnosis and treatment and care for people with specific illnesses. And this is really a crossover kind of an ECHO that is putting both medical professionals and community professionals together, and caregivers, to be able to say, how can we better build a stronger bridge that goes both ways? And so this isn't about medical professionals teaching us about how to care for people with dementia, and it's not about community members telling medical professionals what they need to be doing. It's really about how do we begin, how do we take the good collaborations the very strong collaborations that have been developed across our 3 states and what we know about collaborations nationally, and help others see what's possible, and really build a bridge that goes 2 ways between healthcare professionals and community-based providers to make sure that we're building the strongest team around people who are living in the community with dementia and their caregivers. That said, we want to make sure that everybody with these didactics really has that their overall knowledge increases about both the necessary care of folks with dementia, as well as community supports that help and around specific issues related to their care, or ways that there may be presentations that, anyway, whatever. I'm going to just leave it there and say we wanted to take a few minutes to really brainstorm with you all what kinds of didactics you think that we should be presenting to sort of these community groups who will be the spokes in our ECHO. So I'm going to stop talking there and just open it up for conversation. Tom.
Yeah. So
you don't have to raise your hand, by the way.
I know. I feel like I'm in a classroom. I've actually mentioned this to Jess already, but I've done a lot of work around driving fitness and dementia, and that would be a topic that I would be particularly interested in speaking about if there's a slot. So that's all.
Thank you, Tom. You're slotted in for January.
Tom gave his driving talk at the Bar Harbor Geriatrics Conference last year. It's great. So I totally endorse that one.
So again, just thinking about the fact that we'll have some pretty interesting multidisciplinary teams of providers and community members and healthcare folks coming together, what would you, let's just say if there were one thing you wanted personally for them to hear about, what would that be?
This is Laura, supporting caregivers.
So available supports for family caregivers.
Yeah, hi, this is Allegra Miller. I am the caregiver, a caregiver at this point, I guess. I would agree with that. And I know that there are a lot of different programs out there. I know personally I took and am still taking part in the CARES program, which is offered through the UVM memory clinic. And, it changed my life. So the way I'm able to provide much better support for my so I would echo that.
Excellent. And Kat, did you have something to offer?
I was wondering if it might be possible to talk about some of the programs for people with dementia to help with behaviors.
And do you have a specific idea?
Well, I was wondering if maybe someone could talk a little bit about the REACH program and some of the other interventions like music and memory. Actually, we do that. I'd be happy to contribute to that. But anything else that's out there that we don't know about yet?
This is Peter. I was wondering if we could perhaps talk on the caregiver resources, like talking about how to bring caregiver resources to a community when they're not available, such as education programs and support groups. You know, we could also talk about Savvy Caregiver and other things that might be state specific, but just how to bring those resources to communities and increase awareness when they're available.
This is Ellen. I think that it might be helpful to take a look at the guardianship issues. We have a lot of people with dementia that are living alone, and how do we manage them as a community?
This is Mary Val Palumbo. I lost my video when I was eating my lunch, so you'll have to imagine me back. Now, I don't know if this will fit in at all, but I just did a sabbatical in New Zealand studying Alzheimer's disease pathway for care there. And, you know, what I brought back is the lack of a clear pathway for people and caregivers to get support from their primary care providers, as well as their communities and the resources. So it's a little bit more on the policy side, and what things might be possible if we had some recognition of this disease as a tremendous drain on our resources. So I'll stop there, but that's what I don't know if it will fit anywhere.
This is Allegra. I'm just going to chime in on that. I think that that's an excellent idea. I know I just went to the doctor with my husband to his primary yesterday, and she thanked me. She said, "I learned so much from you about what's in the community. I really thank you so much for telling me." And it just struck me that why, Vermont's kind of small, and why doesn't I live in Chittenden County, which is we're a big hub, and where's the lack of communication? Like, how did she not know about the different exercise programs and nutrition? Just different things that I have come across because of, I don't know why I have, but just been very, very fortunate and connected with the right people. So I would echo that 100%.
And this is Anne Marie, just to jump off on that. My background's in the medical model, but a lot of what I do when I work with the caregivers and I teach the Savvy Caregiver Program is really that partnership, and how do I become an advocate in the medical setting, and how do we start to integrate that medical model with the community setting, because you have to have that integration in order for these, especially those elder orphans who don't have caregivers, to really get good health care. So I think that's just kind of how do we help support caregivers to be advocates and well-informed, and also to have the right tools so when they do go in to speak with their providers, they know what to ask for.
This is a lovely thing. Could I just get some clarification? When you say community setting, are you talking about daycare, an adult daycare, or a residential place? Or are you talking about a home, or am I being too literal when you say community?
I'm talking across the entire continuum. So it might be visiting nurses, it might be like the senior companion program we have here, it might be the REAP program that I direct, it might be the day out program, it might be the plethora of community resources that we have. So when I was in Gero Psych, and I would have patients come in to see me in my like neutral little office, I would just see what was in front of me. But a lot of times there were other things happening in the community that the community providers were seeing, and I wasn't necessarily getting that information. And some of that information was really critical in terms of supporting the family or the patient, or helping to figure out when we need to move to that next level. So how do we start to kind of marry those two? So we have, I love HIPAA, I hate HIPAA. How do we get those two pieces to go together more effectively?
Thank you.
Cliff, you had one suggestion. We're going to take this last one so that we can stay on track, but go ahead and share. And then I just want to mention that as you're all thinking now about these topics, to continue to think about them, send them in the chat or send it via email, because we do want to capture everybody's recommendations. Cliff?
Thanks, Lisa. I actually have 4 recommendations. One is sleep as both a symptom and a risk factor for Alzheimer's disease, and sleep also pertaining to caregiver well-being. Differential diagnosis, so that people have a better sense of what the terms mean. the different diagnoses and how that relates to the different presentations or symptoms of different neuropathologies. An update on research, particularly on Alzheimer's disease, how to find clinical trials, what's the relevant of research for families. And the last suggestion would be end-of-life discussions, how to approach the topic and how to have the discussion.
That's awesome. Thanks very much. And I think we've got some folks who are weighing in on the chat, so thank you for that. I'll also add my 2 cents that we might think about doing something around building dementia-friendly communities. So turning back over to you, Ellen. Elise, sorry. I was looking at Ellen.
Thank you, Jess, and thanks for all of those folks that are chatting in their suggestion. Just really great ideas. So continue to chat in. We are now going to kind of transition over to actually how does ECHO work and what is this all about? So we're going to have Jonathan kind of lead this session for you.
All right, let's get back to the right. There we go. So some of you may or may not be familiar with Project ECHO. So Project ECHO is actually an acronym for Extensions of Community Healthcare Outcomes. It's an educational model that was developed by Dr. Sanjeev Arora and fellow researchers out of the University of New Mexico School of Medicine back in 2003. It's a nonprofit movement to improve care by gathering a community of practice together for learning and support with the goal of improving decision-making and collaborative problem-solving. So a community of practice refers to a group of people who share a common concern or passion for something that they do and learn how to do it better as they interact regularly. So the mission statement, the overarching mission statement for Project ECHO is that it's a movement to demonopolize knowledge and amplify capacity to provide best practice care for the underserved people all over the world. This is achieved really by linking content experts such as yourselves. And so that is referred to usually as the faculty. And linking that faculty to participants that wish to increase their capacity and knowledge in a specific subject matter or discipline, which then we refer to those people as either the spokes, the learners, the cohort participants. So you may hear those terms all being used at different times for those people. So through a series of virtual learning sessions, so a session like we're doing today, which we either refer to as ECHO sessions or tele-ECHO sessions. So in those sessions, the expert faculty mentor and coach the learners via a case-based discussion and a didactic education. So there really are 4 core principles when it comes to the ECHO. And doesn't matter what content you're delivering, so regardless of those topics, these really kind of follow the 4 core principles always. So we have use technology to leverage scarce resources. So what we're doing right now, utilizing Zoom to deliver those sessions, sharing best practices to reduce disparities, utilize case-based learning to master complexity, and then tracking data to monitor those outcomes so we can really see is how are we doing? Are we moving the needle, and are the objectives that we set out to conquer, are we doing that? Are we getting those done? So these diagrams kind of really show the flow of knowledge during an ECHO session. So it doesn't matter which ECHO session, what content you're looking at, this shows the knowledge that kind of flows from the hub to the spoke, so the faculty, you all to the spokes, and then from the spokes back to the hub, and also from the spokes to the spokes. So it just shows that multi-directional flow of knowledge, and that it's really an all teach, all learn model. So that kind of just highlights a difference between a traditional webinar that we're all kind of used to joining during our lunch breaks and an ECHO session. And that all teach, all learn method. This so really, Echo is just this as a methodology. So it uses the Zoom software as its delivery platform. It's not a webinar or a conference call or a stream session to observe. It's really just that methodology to deliver these sessions. And one thing is Echo really does rely on active participation from everyone, our faculty, our participants, to really drive that session. And so it uses that structured approach to democratize knowledge via the spokes to the hub and the hubs to the spokes. And then this kind of just highlights another part of Echo is that with traditional telemedicine, it's a one-to-one approach, but with Echo, it's really a one-to-many. So our hub team is, coaching and mentoring many spokes who are then delivering what they've learned to many, many patients. So it's really an amplification of that knowledge. So let's go over the anatomy of an Echo session. With talking about the structured approach, this is kind of the anatomy that way back when they decided to start doing Echo, they said this will be the best way to achieve what we want to. Every Echo session will start out with just a brief welcome and announcement. Most likely it won't be the same that we did today because unfortunately due to time, we won't be able to always do a nice long little introduction for every participant. So it'll be a little bit shorter. Then we'll go right into our brief didactic section or our mini lesson, which sometimes we may refer to it as. After that, we'll do a roll call. That'll give us just a real quick time to do attendance. This is really important for people on the phone who can't chat their attendance in. We'll ask them to unmute and just say their name and organization. And then followed by jumping right into our case presentation. Every case presentation follows this very strict kind of process, and it'll always be the same. Our facilitator will ask the case presenter to do their case presentation. That'll be usually between about 3 to 5 minutes. First, we'll go ahead and ask for clarifying questions. So this is time for you to really kind of dig into some more detail in the case, ask anything that didn't make sense, if there's anything else you'd like to know. But we're always going to start out with our participants first. So this is the hard part for the faculty is really wanting to jump in and dive right into the case. You kind of have to sit back and let the spokes or the participants do it first. Give them the time, give them the opportunity to ask those questions first, and then after that, we'll go to the faculty for clarifying questions. We do the same thing for the recommendations. So we'll go ahead and start with our spokes and our participants on the phone, the ones on video. And once they've been able to weigh in and give their recommendations, we'll then transition over to our faculty. So then a note taker, who we have designated as Patricia will be taking notes throughout the case presentation. And we'll kind of just do a high level summary, 2 to 3 minute summary of those recommendations. We'll ask the presenter always if, did this help? Was this whole process helpful for you and your team? And then we'll go ahead and do some closing remarks and we'll end the session. So what information should be included on a case presentation form? So we'll again ask the participants and their teams to present a case during the session. These cases really should be urgent, complex challenges. This may be a little different for our program where it's not going to be as patient-centered. So it may not be a really urgent, complex case. It may be something that they've run into in their community, how they'd like to maybe better the flow of patient care that they're offering. So it may not be exactly that. So we will provide a template, which we'll take a look at here in a moment. Only de-identified information. So if it is involving a patient, of course, we don't want to put any identifiable information on there. No PHI, so we make sure that everything is scrubbed, and we also do that on our end as well. When they present the case, we go through a nice vetting process to make sure nothing is on there that could identify a patient. And then there is a main question, and that's a big thing, is kind of to really focus the main question out, so that kind of drives the conversation. So we know kind of how to frame up our questions and our recommendations around that main question that they're trying to, or the main challenge that they're trying to overcome. And again, it says it's critical for us to preserve the confidentiality of it, whoever is being presented on that case. So during the echo session, facilitator again calls on the presenter. They summarize their case in 3 to 5 minutes. And then again, like we just went over though, we'll go ahead with clarifying questions, then recommendations, and we'll go ahead and do the note taker. So that kind of just goes over that same information that we covered. So now the case template, give me a second and I'll bring that up. All right, so can everybody see that? I'll blow it up here a little bit for you. So this is the case template that we've put together so far. This document is not static. It can transform if you guys have feedback, something you feel like should be added to this case template. By all means, let us know, and this can evolve over time to add more information that you feel should be on there. So it's nice. There's little areas that you can just click and add the text in. I won't go through everything here. We had sent this out, so everybody should have this. So this is just what they're going to be asked to put their information in. And we offer that if they have any questions or concerns, that we're always here to help them, guide them through this process. We usually say that it shouldn't take them more than 15 to 20 minutes to put their case together. That's not always the case, but we hope that it doesn't take them a lot longer than that to do. So I'll just scroll through real briefly here. And then one kind of thing here to highlight, the kind of initial here's, and I think we're going to get to it in a minute, but this echo process doesn't create any relationship between our faculty and our presenter. So if there's any recommendations, we're not creating a relationship, a patient-provider relationship between anyone. The person that they're talking about is still in their care. So it's at the end of the day, if it's a recommendation, it's still their choice whether or not they want to fulfill that recommendation. So just kind of know that you're not entering into any patient relationship. All right, let's go through these. I am being told that I need to go quickly, so I will, which means I won't, actually. Let's see. So no PHI. It's also right here. And this again just says that same thing that we just covered, that it doesn't create any patient-provider relationship. A few just things to kind of keep in mind, and doing a lot of these, I always like to think about it is kind of on the bottom here is how can we make a warm, welcome environment for everybody that's in our session, where by nature, we're on a video conference. It's not homey. It's not, sometimes pleasant, but we want to really create that environment for everyone. So ground rules, establishing those, that could be things like, what do we call people? If sometimes we'll say, name yourself what you'd like to be called. Some people like to be called by their first name. Some people don't. So we kind of create those ground rules to make everybody feel welcome. Including everybody, no matter who they are, whether they're on the phone, the video, in the room, talking to everybody as though they were in the room with you, making eye contact. That can be hard when you're on a video conference like this, because the eye contact really is at your camera. So you kind of have to be mindful when you're looking at your camera, you're actually looking kind of at everybody. And then gentle suggestion / redirection, that just means as a faculty member, if something is said that you don't necessarily agree with or is maybe not correct, to kind of gently redirect that conversation in the direction you'd like it to go, not being really direct and saying like, no, that isn't right. Some behaviors to avoid, just obviously talking over people. It's hard with this kind of session because we kind of say, I'll jump in and say things. So just be polite. Oh, I'm so sorry. Please go ahead. I'll go after you. Eliminating distractions, so just not crumpling paper, behind the scenes. Be mindful that the audio can really pick up a lot. So if you have dogs, that you make sure that they are at least a little bit quiet, or like in my case, my children, I lock them in the basement when I do sessions at home. Just kidding. Don't call DHHS, please. Avoid side conversations and just no shaming or embarrassing people. I won't go through all these. You have the slides, just a few more things to kind of think about with behavior when you're on a tele-echo session like this. And just letting you guys kind of know what goes into an echo session. There's a few different roles. You fulfill the consultant role kind of on this, the faculty. We have IT, like which is Annie is doing, a facilitator, which Jess will be doing, and then coordinating, which we kind of all are doing really, is making the session run smoothly. And the annotated schedule for our sessions, we kind of went over this, so I won't go into it really in depth because we're going to jump in and do some like role play here. This is going to be super fun. We're going to do a session. So just remember the annotated schedule. We start the session out. We welcome everybody. We do our didactic. We do a brief Q&A if possible, if time allows. And then we jump right into the case presentation. We do clarifying questions first always, and we go to our spokes and our learners and let them ask those questions first before we jump in as a faculty. And then we do our recommendations. Same thing, we let our spokes or our learners do it first, and then we jump in after. We summarize everything with our note taker, and then if time allows, this is an open panel discussion, but we probably won't necessarily have that much time in our sessions, and then we close. So now, time for the fun.
Yeah, thanks, Jonathan. Yes, time for the fun. So you can stop sharing. We are going to go through kind of like a mock. That's what this is all about. We have a case presenter. Jess is going to present a case. She'll give us, it'll take maybe 3-4 minutes to go through it. I believe you've all received the actual case in your materials that were sent electronically. Then we're actually going to go through the process. So after Jess presents her case, Jonathan's going to be our facilitator. And you all, what we've decided is the folks from Maine will serve as faculty. And then anyone from New Hampshire and Vermont will serve as our participants. So as Jonathan will give you some prompts. So if you have a clarifying question, remember to unmute yourself. If you're on the video platform, just unclick your little microphone. And if you're on just the phone, it's *6. So we are going to turn it over to our case presenter. And typically, we will introduce the case presenter, the community that they're from, their name, their organization. So just as a precursor, that's our typical process. So Jess, you have the floor.
Excellent. So I'll offer that a couple of things. First, that I am also the co-chair of a small community effort here in Maine called Harpswell Aging at Home. And while this is a mock case, it's an actual true case, but I also only have so much information, I think this is more the reality of how things happen. And so this is a situation of an 86-year-old man who lives alone, who says he has no relatives, although some people believe that he, in the past, has mentioned a son. He has no current social supports, is still driving, and our biggest question really has been, how do we build better community supports around an older person who's living in our community with mild to moderate dementia, who's living alone with no family. And this situation comes to us literally, we've got this little community group that does all volunteer initiatives, volunteer transportation, volunteer home repair, volunteer food programs here in our community, and our phone numbers out there everywhere. And so we get a phone call from a person who says, I'm the neighbor of this gentleman. And what happens is that he's been calling 911 when he needs something, and the sheriffs have come to his home several times. They say that everything is in order in his home. He's neat and tidy. He has food in the refrigerator. He doesn't seem confused when he comes. And eventually, after this happened a few times, the law enforcement officers figured that somebody had told him to call 211, but he was getting confused and calling 911. And so they did redirect him to 211 as a resource. But the neighbor called predominantly because they're new Mainers from out of town from North Carolina, older retired couple, and he came to their house at 10 o'clock at night, having locked himself out. And they weren't sure what to do, so invited him in, had him stay there, and the next morning with him broke into the house, broke a window, got inside, and he became very agitated and said, "We have to fix this." They took him over to Lowe's to get the materials to fix it, and when he got there was completely confused about why he was there and really wanted to go home. They were reaching out because they didn't know what to do. They really were concerned for their own participation in this process, having broken a window and, having the sheriff coming in and out of their community, and they were worried that, maybe they would do something, that he would then accuse them of stealing something. So we're worried. We made an initial, sort of referral to Adult Protective Services, to the Alzheimer's Association, and to the local area agency on aging, but really our community group has no experience or capacity to support this gentleman living in the community. I do know that she did reach out to APS and that they did not decide that he needed, that they were going to do any sort of an in-home assessment with him. Months go by, and then we get a call, I get a call actually from our town manager, and she's gotten a call from a bank in Brunswick, Maine, and he presented saying he had lost the key to a safety deposit box, but he absolutely had to get into it because he needed to get something out of it or he'd be in trouble. They called the town manager really worried about financial exploitation, and wondering if there were any supports in the community or if he had family that they could be connecting with around their concerns. So again, I reached out directly to the Alzheimer's Association and found out that that they could do a home assessment, a home visit, and that we sort of brainstormed how to do that. And decided that it would be good for a deputy sheriff who'd already met him several times to go with a person from the Alzheimer's Association and introduce them and see if they could go in to to do some sort of an assessment and potentially hook him up with services. That's it. I don't actually know if the Alzheimer's Association did go in. That was the plan, but we haven't gotten any more calls. So I think this is not an unusual situation in the sense that when things happen in a community where there are no known relatives, that local community groups get tapped to try to find solutions, and the solutions aren't readily apparent. So that's my presentation for a mock case. Although I will say, Peter, you may know the end of the story. You might not. Then you go. See, Peter knows nothing. So there you go. That's the end of it. That's so thanks. So I guess now we'll go to questions, right?
Awesome. Thank you very much, Jess, for presenting that case. And so at this time, our facilitator will kind of do a summary. I'm not going to torture you all with my summary of this case. So, but I will frame up the kind of main question in your case, is how can a community better build supports around an older person with mild to moderate dementia who's living alone with no family? So what we'll do now is we'll start with our clarifying questions, and I'd like to go to our participants or our spokes first. If we have any spokes specifically on the phone, it's *6 to unmute. If anyone would like to weigh in with clarifying questions, please do so.
Did Spectrum Generations receive the referral? Do you know?
I had direct interaction with the neighbors and referred them to Spectrum Generations. I do not know if they called, honestly.
Okay. They also do home assessment, so.
Yes, and that's what I had suggested as well. That they, again, I had no direct I don't even know the gentleman's name, and was trying to brainstorm with this person, and sort of walk through what would happen if they went to each of these organizations. And I know that they did reach out to Adult Protective Services because I think they thought that might be the easiest solution. I'm guessing that they also did call Spectrum Generations. I'm not sure SpecGen would have gone out, and that would be maybe a question for the AAAs, without having some sort of contact with him first.
Two questions. The first one, do you know if they reached out to APS after the second concern around the financial?
No, it was after the first.
Okay, because I think this is one of the challenges, because I know in New Hampshire we now have it that would be an automatic, we call BAS referral for follow-up. So it doesn't sound like that may not necessarily be the case in Maine. The second piece is, does anyone know who the PCP is, and does a PCP have like a nurse coordinator or social work coordinator in the outpatient offices that can maybe follow this patient, start to develop a relationship?
Yeah, and the answer to the latter is no. We had no knowledge at all of his primary care, and again, I don't think anybody was asking, and there wasn't a care coordinator here or any sort of person in charge. I think that's part of the biggest challenge. When you have a neighbor who's presenting to literally a volunteer group that doesn't do this. I just happen to know more than other people do, so of course I got to answer the question. This is what the real life. If I hadn't been part of our community group, I don't know what the answer would have even been, or if they would have even provided an answer to the situation. So yeah, we did not have any connection with with either behavioral health or medical provider, and I am fairly certain that the bank would have also reached out to. In Maine, we have a process where they reach out to the Office of Securities. They're the sort of primary contact, and from there they will do outreach to other agencies. And I can't say if that happened or not.
I'm going to do a timeout here. Hold on. Those are great questions. I do want to clarify something as you're presenting your clarifying questions or your recommendations. When you use acronyms, if you could be mindful to, instead of using the acronym like the APS or PCP, not all individuals in the community will know what those acronyms are. So it's very helpful to, particularly if it's a very complicated one, just be mindful of that. And for the sake of time, we're starting to butt up against the end. We're going to segue to faculty clarifying questions, and that would be our main participants.
So I'm just going to jump in quick here. So there's an interesting disconnect in this story. Usually when you have somebody with potentially this level of dementia, you see evidence in how the home is arranged, and particularly what you see in the fridge. And yet that's not the case here. And it does make me wonder, is there an informal caregiver somewhere that we just don't know about?
Thank you, Tom. Other faculty members, we have Caitlin. It looks like you're unmuted. I scared you into muting. Anyone else? We have Peter, Tamara, and Cliff.
Yeah, this is Peter. I agree with Anne. Like, is this an opportunity to try to find a way to connect with a primary care? Because that seems like a really good connection to get us some more data, and also make sure that the doctor is aware of this. Is this an exacerbation of his normal cognition due to a delirium, due to a drug side effect? And sometimes, making sure the doctor is aware that there's really this level of cognitive change, I think would be helpful.
Yeah, this is Cliff. I agree definitely. If the house looks to be tidier than you might expect someone with this level of confusion, perhaps it is a more acute process. And that raises the level of urgency of getting an assessment.
Looks like Tamara wants.
And just to kind of do a general reminder as well, faculty, when we're doing our clarifying questions, which we're in now, make sure we're trying to really frame those up as questions and not do I'm going to ask a question that's really kind of a hidden recommendation, which it happens every single session. So it's okay to say, I don't have any questions, they've all been asked, and really try to hold off on those recommendations or those kind of reflections until we get into that section.
Right, I'm an old pro at that, and I still screw that one up.
So
I'd like to know if he's a veteran.
Good question. I don't know the answer to that. But it's a very good question. And, I will, sort of go back to say, for me personally, the challenge is no one actually knows this person or in the community has observed this person. And so we tried the best we could, try to get somebody with a trusted source, i.e. the police who'd been there and he was welcoming to them. With someone who could do something about it, but there was no one in charge in this situation. And I think that creates that problem of who does what, and do we take it on ourselves to do more, or what is the right thing to do there? Who else do we refer to?
So we will go ahead now and transition over to our recommendations. Let's go ahead and start out with our spoke and our participant learners here on the phone. So if anyone is on there, you can star 6 to unmute or unmute your audio on your computer and do some recommendations. And I don't see any, so we are going to turn it now over to our faculty members.
Can I do another timeout? Sorry. So another process that we do in ECHO is we really try to give a lot of time. Really, the standard is count 15 seconds, and it seems like an awful long time, but it gives our participants as well as faculty the opportunity to form their thoughts and their responses. So we don't want to cut them off. So if it seems like a long pause, it's intentional. Thank you.
Can I just offer, or at least my thoughts? So as we're talking, what I'm hearing more of is maybe more of a systemic piece around, you've got this volunteer group, these cases are coming up. I'm assuming this probably isn't the first one and there are going to be more. And I'm wondering if there's a way to put some sort of process in place that they may feel a little bit more support, that they can bring it back to whoever that point person might be at the agency, that they can, do a presentation or a supervision with and say, okay, what should be my next step? And then that support thing can then be provided in terms of, do we make a referral? Do we need to get more information, et cetera, et cetera. I don't know if that's already in place or if that might be something to look at.
No, I think that's exactly right.
Can I say something?
Oh, of course.
Okay, so, it sounds like nobody knows him very well, and I wonder if there's like a church group, someone from a church or someplace who would just be willing to befriend him and get to know him better, so that a clear understanding of what he needs and how to go about helping him could be evolve a plan.
And he was referred to a number of our community organizations, but we did not go that far to try to hook him up with, because we don't have that program, but we could try. I mean, I think that's the challenge of a volunteer organization that are already doing incredible. They're already overstressed with the really wonderful volunteer things they're doing, and I think it's terrifying to them to think that they would become responsible for a community member that's not their family.
Yes.
Isn't that what a dementia-friendly community is all about? I know in New Zealand they had little symbols in some of the businesses that their staff had been trained to, you know, deal with someone that had dementia. So that you know, that's the whole system thing.
So any other recommendations from our faculty? We have about a minute.
Yeah, I think I'll just add, I think Cliff's suggestion that this could be more of a temporary exacerbation or worsening of a delirium is really worth considering in this case. I think the other issue I would raise is that whoever is going to do the intervention really spend some time listening to this gentleman and what his wants are, perceptions. It's so easy to get worried and jump to the conclusion that he doesn't have an opinion or can't express it. So anyway.
And, you know, I'll offer my own, sorry about the dog barking, Jonathan, nothing I can do about it. My own, you know, sort of, I had to answer the question, what would I come up with as a solution? And the two things that occurred to me is that I could have asked the Alzheimer's Association to come to a community meeting with our volunteers and volunteer leaders to help us begin to think about how we can better support people living in community. The other one is that in some places in Maine, there are what are developing into what's considered vulnerable persons registries, where people can self-select onto them, and you know, can offer the name of their person that they want contacted in the case of an emergency, and also can ask for well-being checks on a regular basis if they're worried about their not being, you know, someone there with them, or after a storm or that sort of thing. So I think those are two things personally that we could do here in our community, at least to begin to make a better support network for folks who are living with dementia in our community.
Excellent. Well, thank you all for your recommendations, weighing in on this amazing case. Thank you for bringing that forward today, Jess. And so this is where, you know, we would have our note taker do a high-level summary of the, you know, recap of our recommendations, and then we would say, you know, was this a helpful experience for you and your team presenting this case today with the feedback? And of course, they'd say, yes, this was amazing, and we would say, thanks. And so other than that, that would really conclude our case.
Yes, thanks. So now we want to just open it up and do a little bit of a debrief on your experience. And, you know, anybody can share what worked well, what do you have questions on, what do you need more, you know, training on, if anything. So how did it go? How do you feel? I think you did an amazing job. You really got this for the most part. I think this is going to go really well because you have the process down pretty well. But if there's any questions, this is your time to ask them.
I'll just jump in and make a comment that this is now the second ECHO I've participated in. I did one with our College of Nursing last week. And same experience today. The time management part of this would be a real challenge to me, and I appreciate the way it's run.
Thank you, Tom. Other thoughts or comments or on the process? Cliff, you're awfully quiet. Where is he? Did he leave?
No, I'm here.
Oh, there you are.
No, you guys are doing great. I've got nothing.
Thank you. So we, if there's no other comments, we did record this session, and we will share it with all of you as well as those that were not able to attend. Our next steps, we have developed some evaluation tools that will be administered to the participants. And we would like to share those with you for your thoughts. So we have a pre-assessment that will, all of the participants in the program will do. And this is basically to gauge their level of confidence and capacity in a number of areas. Then there's a second evaluation that will go out after every single ECHO session. And that is more in line with how did the session go? Did you learn anything new from the didactic? What was your experience with the case that was presented? Were you able to implement some of the recommendations or strategies that were discussed? So there's two very different evaluations. So I would like to email those to you. And you're welcome to weigh in and share your thoughts. In addition, we did capture quite a few didactic topics. Jess and I will go through them and kind of meld them together and come up with some potential topics over the sessions. I'm sure she will be reaching out to each of you in regards to who would be interested in presenting on those didactic topics. If it's your comfort level, such as Tom, he's quite an expert in the driving arena. So we're looking forward to that. And I see, let's see, Ellen as a community agent.
Did you want to just unmute maybe?
You want to share that, Ellen? If you want to unmute yourself and.
Sure. I was community when I was the parish nurse here. This was probably 6 or 7 years ago. And we had a community-wide conversation about aging in place and invited the whole community to come. We ended up with a little over 120 people, and others, kept sending us information afterwards about what their thoughts were. At the end of that conversation, everybody was like, well, we really just have to be more neighborly. And so we challenged the group to go and meet their neighbors. If there were people in their little area, we're quite rural. And so sometimes it was like a half a mile down the road to meet the people that maybe had just moved in or people who had been there for a long time that they just didn't know. And this yielded a few referrals to me as the nurse in town and to our Aging in Place group, and allowed us to introduce ourselves as either a support or as both of us as supports, but in different ways, and allowed us to ask about contact people. So do you really, I see you living here alone, who's your family? Where are they? And that kind of thing. And it ended up that we were able to then get in contact with family members if they thought that was okay. So there was a lot of building relationships and everything, but it actually has moved our community, I think, to a place where we do get referrals, a fair number of referrals from folks who are just neighbors who are concerned about their friends. So.
Thank you, Ellen. That's a great recommendation. We are at time. Thanks. 2 more minutes, and thank you for some of the comments that was sent through chat. We appreciate that. We have our first ECHO session, October, remember the date? It's in October.
It is October.
Participant orientation is September 26th.
24th.
However, you do not need to attend that, but you're welcome to. It's not mandatory. And October 24th, that's our first session. That is our go live. So thank you again. Jess,
I think you're on the 26th, which is the Thursday.
September 26th.
September.
Yes, that is the participant
Thursday.
Orientation. Yeah, that's the participant orientation. It's a similar format as what we did here, but it's a little bit more geared to like the case presentation. How do they, submit those cases, the technical aspects. So again, you're welcome to attend, but it's not mandatory. But we will see you in October on the 24th. Is that right? Jess, you got the floor.
Great. Well, I wanted to say thanks to everybody, and also just wanted to offer the briefest of updates on our participant search. That tomorrow is the deadline for applications, and so just wanted to let you know we do have 3 great applications from New Hampshire. We have 2.5 from Maine. 1 was incomplete, and know of a couple of more that will be coming in. Just heard that 1 is definitely coming in from Vermont, and are working on the last 2 from Vermont. So we're really excited. I mean, we're thrilled that we put this out there to communities, and communities have stepped up and are excited to be participating. So thank you all very much for being the faculty for this project.
Great. All right. Any final comments, thoughts, questions?
If anyone has technical challenges, reach to myself or Annie offline, and we'll kind of walk through those. So like, I think Allegra will try to figure out the webcam, see what's going on with that. And if anyone else has any, just let me know.
Thank you, everyone. Enjoy the rest of your day.
Have a great day. Bye-bye.
Jess,